we're going to start talking about growth and development. I always like to start with growth and development when we start with pediatrics. And the reason I like to start with growth and development is because you need to know what the norms are in order to be able to understand what the abnormals are, when things deviate, when there might be a red flag in development, or any other problem that may arise, or questions that the family may have. If you don't know what normal patterns of growth and development are, and what is expected for the infant, the toddler, preschool, school age, or adolescent, then it's kind of hard to address any questions or concerns a family may have. So, we're going to actually start with why growth and development is so important. Um, and that's starting right with your infant notes. So, with growth and development, we need to have that knowledge and what that sequence is, and that's so the nurse knows um, what is normal to assess for growth and development. Again, with development, with motor skills, and to be able to help monitor for abnormal deviations. It also helps parents to gain that realistic expectations of their child's capabilities. So before I start talking about health promotion and maintenance, um, for those of you who've had kids, maybe some of you are still in the infant stage. Maybe for some of you it's been a while or hasn't been that long. But when we think about growth and development, whatever age group we're talking about, not just the infant, um, there's a lot that happens at those well child visits. For those of you who maybe don't have kids and you're going, great, I'm screwed. No, you're not. Guess what? You don't know any different than what I tell you. You're a blank slate. The people who have kids, they tend to start thinking when it comes to test questions and their experiences, they think about their own kids. And usually, if they only have one child, it's a little bit harder to see that things happen at different times for each child. Those who have multiple children, they can see each child will develop those developmental milestones and those growth markers at certain there's certain times that we like to see them. There's average ages, and that's what we're going to talk about today with growth and development. But when we really think about multiple kids, yes, there's an average time frame that they do these things, but every kid is individualized. And so some are a little bit faster at hitting certain developmental milestones, some are a little bit slower, and some are right on the mark. So for those of you who, like I said, who don't have kids, it's okay. You're a blank slate. You don't have anything to compare to other than what I tell you. It's the people who have kids that start to think about their own experiences with their child or children that really starts to trip them up. I'm not asking about their kids or their experience. I'm asking about what are the average ages that we typically see kids hit these growth and development milestones. So, with that being said, for health promotion and maintenance, like I said, for some of those who either are in the infant period, maybe it's been a little while or hasn't been that long, we go to routine checkups. We take these infants to these routine checkups on regular basis, and there's lots of things that happen in those well child routine checkups. In the infant age group, and really infants is defined, what I didn't say, infants is defined as 1 month to 1 year, 12 months of age. That 0 to 1 month period is actually considered the newborn period, and that's really going to be covered more so in OB side of things than it is with pediatrics. We have a little bit of an overlap, but the infant period, like I said, really starts with 1 month to 12 months of age. So during those routine checkups, what we like to see is usually in the newborn period, they go for their after they've been delivered, they've been discharged from the hospital. They'll go to their first pediatrician or family physician just to kind of establish that baseline for that infant. They'll usually do that within a couple days of discharge from the hospital or a home birth. And then usually we see those routine checkups at 2 weeks, at 2, 4, 6, 9, and 12 months. And during those routine checkups, we monitor different things. One of the big things that we're going to monitor for your blanks, we're going to do length, we're going to do weight, and we're going to do OFC. And OFC stands for occipital frontal circumference, which really just means head circumference. That's all we're doing. We're measuring their head. So we're going to get those lengths, the weights, and the OFCs, and we're going to plot those. We're going to plot those on a growth chart for each individual measurement that we do. And what we do when we do growth charts is we compare them to the average of what we typically see with other kids in those age. And there's one for boys and there's one for girls. So I have some examples of growth charts in a little bit when we come back to those measurements. But like I said, we do length, weight, and OFC. We also talk about developmental tasks. Are they on target? When we talk about developmental tasks, there's 4 big areas that we're going to look at. that you'll see as a recurring theme with each age group that we go through, and that is gross motor, fine motor, social emotional, and language development. So we hit and see or really start asking parents, are they able to do these different tasks? Or as the child gets a little bit older, some of those things we can observe. Or we can ask the child, can they do those things? As an infant, obviously you can't. They're not going to follow command. But there's certain things we can certainly observe if they do, or rely on what the parent is able to tell us. Right under your next blank under developmental task, every appointment, it seems like, especially in that first year, what do you think they're going to get? Immunizations. Lots of immunizations. We'll talk more about that in the next slide in just a little bit. But for your blank, they're going to get immunizations. And then, of course, it's always a great time to do teaching, talking about anticipatory guidance for the family, safety measures, and certainly discuss any problems or concerns that they may have. I already had said we do a lot of immunizations in that first year. Immunizations are really important. Um, we do immunizations for a variety of reasons, despite whatever maybe your personal belief is or what other people are saying in the healthcare setting. We really do promote immunizations and keeping up on top of those schedules. Before I get into kind of like filling in the blanks of your note, um, we know there's lots of different opinions out there about immunizations, and I'm not here to argue the right way or the best way, but just saying that you have to make sure that we're educating somebody. If they're choosing not to vaccinate, if they're part of the anti-vaxxer movement, that's their opinion, and that's fine. They're entitled to it, but making sure that they have the right information and the right knowledge, because there's a lot of misinformation out there. There's still very much the belief that particular vaccines can cause autism or other certain developmental problems or other medical issues, but the big one being autism was surrounded by, if anybody knows, if you remember, what do you think, which vaccination do you think that one is surrounded by? You're thinking to yourself, MMR, measles, mumps, rubella, you're right. There was a whole study, I don't know how many years ago now, but quite a while ago. Remember that there was a physician in another country who said, oh, the MMR vaccine causes autism. And that belief is still widely out there. However, what didn't come out about in the news very widely is when it was determined he falsified that entire study, right? So information spreads very quickly, especially whether it's right or wrong information. So we have to help the public understand and how to sort out what's good information versus bad information, what's a reliable site to be getting this information from. It's not Facebook, it's not those chat boards or anything else. Making sure if they're going to a site, it's a reputable medical site that's giving accurate information. Again, as long as we do our education, they still have the right to refuse immunizations. The big thing is if they refuse, make sure, again, we've educated them that they have the right information. We've provided them and answered all their questions, that we've provided vaccination information sheets. We've provided adequate resources for them to go to if they want beyond those vaccination information sheets that we get from the CDC. And then the big thing is that if they're still refusing the vaccinations, we just need to document that we've educated, what we've given them, those kind of things. Like I said, they're entitled to their opinion. They're certainly entitled to refuse immunizations. However, pretty much just about any public school that you go to, when those kids start to get into kindergarten, most of the public schools require them to have that. So unless they're going to be possibly homeschooled, I don't know enough about if charter schools, I would think that they pretty much require immunization schedule. You have to show proof of that. So there are alternatives for schooling, absolutely. But usually kind of sometimes it gets caught up, especially if they plan on sending them to public education or even the private education sector. They do have to show proof when they go into kindergarten. And usually, if they're not able to show proof or get caught up on those immunizations after a certain time frame, the school's not going to allow them to come because it's really just not safe. But getting into like your notes and the reactions, when we give immunizations, there's a lot of education. Not only do we want to educate what it is we're giving them, what vaccines and why we're giving them, we also certainly want to give them that education sheet from the CDC. It's the most popular place we get them from. It just tells them all the information. certainly want to make sure before you give it that you get consent. And it depends on the hospital. Is that written consent? Is that verbal consent? You certainly want to make sure you've checked that there aren't any allergies. And then, of course, when we go to give them immunization, probably ideally before rather than after, because their child or the infant's going to be upset. That's not time to educate them because the parent's concerned about certainly consoling that infant. So we want to educate them ahead of time, especially thinking about reactions. What kind of reactions do you think they can have? Where is it going to be? Is it going to be more local? Is it going to be more systemic? If you're thinking local, that's the right answer. It's local tenderness. So for your blank, local tenderness. They can have erythema or swelling at the injection site. And if they potentially could have a fever, do you think it's going to be high or low grade fever from an immunization? Should be a low grade fever. They should not be spiking high grade fevers after an immunization. Low grade fever is normal, it is expected. So making sure parents understand that. And then again, how they can also combat the irritation, the low grade fever, they can just give them simply some Tylenol or ibuprofen. However, I will say Tylenol pretty much can be given just about any age safely. With ibuprofen, though, it cannot be given until they are at least 6 months of age, or unless their family physician or pediatrician has told them otherwise. Always wanted to, like I said, always want to check for contraindications and precautions. Give those patient education sheets. That's a priority. It should be done before the immunization is given, not after. And we want to make sure that if we're using a live vaccination, that we use caution when we have an immunocompromised patient, whether that be from cancer, whether that be from somebody who's got medical disease like maybe not congestive heart failure. That could certainly be one of them, but something else that's certainly going to put them at risk. Lupus, a systemic complication from being immune suppressed, whatever the case may be. Those are important things to give them. And again, make sure we answer any of those questions ahead of time before we actually give them. When you are giving the immunization, oftentimes infants are getting sometimes 2 and 3 shots. And I've seen up to 4 at the max. Probably would never do more than 4 immunizations at one time. When we're giving multiple, important to make sure we document where we gave them. Make sure you also, if you're giving an immunization in the same leg, in the thigh, that you separate that by at least an inch. Because if you don't, and you don't chart well as to where you gave whatever specific immunization, and they have a reaction, it's hard to know which one they reacted to. So documentation is certainly key, and making sure we separate them out far enough so if they would have a reaction, we can determine which one it was they gave, rather than, oh, I don't know, it could be either one of these. You do need to know the immunization schedule for infant, not just infant. I actually suggest that, and you need to know for testing purposes, the 3 big age groups. You need to know infant, toddler, and preschool schedule. I can guarantee you some sort of questions at some point in time, midterm or final, about immunizations. A little trick that might help you, I have at least a snapshot, something called Dr. Hip, as a way to memorize the first year's immunization. So I've included that on this slide. If this doesn't kind of make sense, there's different YouTubes or tutorials you can go certainly have it explained, but it just breaks down. It's kind of a mnemonic way to memorize which immunizations are due at which month. So you definitely need to know your immunization schedule. If you flip over to page 2, I do have it listed out by whatever immunization it is, at which months they would get it. This is the typical schedule. This is the schedule I would base it off of for testing purposes. But that mnemonic, if you really like mnemonics, Dr. Hip is really recommended. So it only does up for the first year. You can find other mnemonics that go on to the other age groups I'm asking you to do, but you need to know your infant, toddler, and preschool immunization schedule. You do need to know the immunization schedule for infant, not just infant. I actually suggest that, and you need to know for testing purposes, the 3 big age groups. You need to know infant, toddler, and preschool schedule. I can guarantee you some sort of questions at some point in time, midterm or final, about immunizations. A little trick that might help you, I have at least a snapshot, something called Dr. Hip, as a way to memorize the first year's immunization. So I've included that on this slide. If this doesn't kind of make sense, there's different YouTubes or tutorials you can go certainly have it explained, but it just breaks down. It's kind of a mnemonic way to memorize which immunizations are due at which month. So you definitely need to know your immunization schedule. If you flip over to page 2, I do have it listed out by uh, whatever immunization it is, at which months they would get it. This is the typical schedule. This is the schedule I would base it off of for testing purposes. But that mnemonic, if you really like mnemonics, Dr. Hip is really recommended. Um, so it only does up for the first year. You can find other mnemonics that go on to the other age groups I'm asking you to do, but you need to know your infant, toddler, and preschool immunization schedule. So this slide just again is a nice little visual and some nice talking points are certainly things to think about why immunizations are so important. And then there's a little video link. It's just a fun video that kind of gets into why vaccinations are funny. I'm all about finding humor and fun things or fun ways to kind of make things stick. So you can click on that baby got vax and it will take you to a short little video about immunizations. Let's talk about growth patterns. Even though we've already kind of talked and hit on measurements a little bit, here's a nice visual. We don't typically do chest circumference or abdominal circumference. That's not something, unless there's a concern, that we do. But remember, we do length. You always have to do length. You cannot do height in an infant. An infant can't stand up. So length, weight, and OFC, or head circumference. And we chart those on those growth charts. And speaking of growth charts, if you want to look at some examples, good or bad, things like where they're growing a little faster than they should, a little bit higher on the percentage of the growth charts, or maybe they're a little bit lower. There's also normal growth charts. If you click on that link for growth charts, it will take you to a website. It's just a quick little reference guide if you want to look at a couple. But let's talk about growth patterns. Growth patterns. There's two types of growth patterns that we see in infants, and that's called the first one's called cephalocaudal, which just means head to tail. So meaning what's going to develop first when you think about one of the very first developmental milestones an infant's going to have. What do you think about? If you're thinking head control, you're on the right track. They have head control first, right? They don't have control, very good control of their arms or legs. They certainly can't sit up right away. That develops over time. So they move in what's called the cephalocaudal direction, meaning from their head to their tail, that development occurs. The other type of growth pattern they have is what's called proximal distal, meaning near to far. So central to peripheral. They don't come out with their hands being able to grab things and pick them up. They usually come out with clenched fist, right? Is that newborn? And then over time, those hands start to open up, and then they're able to grasp things for just a few seconds, and then they learn how to hold on to things a little bit longer, pick them up. They can transfer between hands. That's called our proximal distal growth pattern. And then when you think about the biological development, which really gets into our measurements that I've already hit on, the biological development, it's the best indicator of their overall health. We monitor that by plotting on those standardized growth charts. Like I said, there's different ages growth charts that we use. There's one for boys, one for girls. We use those and we do length, weight, and OFC from birth to 36 months. 36 months is equal to 3 years. And then from 2 years to 2 years to 20 years old, we do height, weight, and BMI. Yes, I know that there is a little bit of an overlap. We do weight and OFC and length from birth to 36 months, but usually by 2 they can start to stand up and cooperate. So usually about 2 years of age is when we actually switch from doing length to doing a height. And then we start incorporating BMI or body mass index measurements as well. Let's talk about how we promote optimal growth and development in the infant. Infants have what's called proportional changes, so they grow proportionally. Typically, we like to see about 5 to 7 ounces of weight gain per week. And by 4 to 6 months of age, what do you think we like to see with their birth weight? What do you think we want to happen to their birth weight by age 4 to 6 months? We want to see that double. So double their birth weight by age 4 to 6 months. And what do you think happens with their birth weight, or what we would like to see with their birth weight by 1 year of age? I'd like to see that triple. So triple their birth weight by 1 year of age. Height increases by about 1 inch per month for the first times 6 months. And then they grow in spurts rather than a gradual pattern. So again, they have these growth spurts, and we can, when we get into nutrition, we'll hit on some of when those typical growth spurts, or at least the first few, occur. And usually what happens when they have growth spurts, family will say, oh, they seem to be, eating a little more frequently, or they're not staying full for as long. I'm having to nurse more frequently, or now they're wanting more than 3 ounces of formula or breast milk if they're pumping. It's just not quite making that. Well, they're probably going through a growth spurt, and that's normal. We like to see that. Let's talk about their physical growth. When we talk about physical growth, one of the things we look at is their fontanelles. They have two different fontanelles in the infant period. And that's the posterior fontanelle and the anterior fontanelle. Posterior fontanelle, where's that? That's in the back of their head, or sometimes people will call their fontanelle, layman's term, is soft spots. So posterior fontanelle is the one that closes first. Posterior fontanelle closes by 3 months of age. And then their anterior fontanelle, the larger one, and that's the one that's up front, that typically closes anywhere between 12 and 18 months of age. When we talk about maturation of systems, we're really looking at how all these individual systems mature over the course of that first year, that infant year. So compared to newborn to by the time they're 12 months, those systems certainly mature, and they're not all fully processing by the time they're a year old, but they're certainly much better off than when they were a newborn. So first one, respiratory. Typically, the respiratory rate over the course of the first year, that respiratory rate will slow and it becomes relatively stable. Now, when they come out as a newborn, they're breathing fast, really fast, sometimes hard to count compared to that adult respirations. Very typical respirations, very even respirations in the adult. In the infant, that's not the case. They have fluctuations in their breathing. They might speed up, then slow down. It's not a real consistent pattern. So their movements also, they tend to be abdominal breathers. So movements are abdominal. They use their abdominal belly muscles to breathe. That's normal. That's expected. Happens until about age 7, and then they'll start to change. And yes, you do still see some chest movement, but the majority of that movement from breathing is in the belly. You'll see that change over around, like I said, about age 7. That's when they become more of, you'll see more chest symmetry and movement with their breathing. So again, infants are abdominal breathers, so movements are abdominal. Also, you have to think about their respiratory tract and how large is it. It's not very big. So unfortunately, just because of how small that airway is, how narrow it can be, and think about when they get sick, if they get a common cold that they have a lot of mucus, how easily that can plug up and clog that respiratory system and causing increased work of breathing. So infants are definitely predisposed to respiratory problems because of that smaller respiratory tract, and they also have an inability to clear mucus and invading microorganisms. And the whole point of mucus is it basically helps to clear when we can cough and clear that and break that up. That's to help clear those microorganisms that get trapped, right? It's a cleansing agent. However, infants can't clear their cough well. A lot of times we need to do things to try and assist them. We'll talk about that when we get to respiratory in a couple weeks. So infants are definitely much more predisposed to respiratory tract infections. Let's talk about the immunologic system. They certainly do not come out with a full functioning immune system. They have an inability of that immune system to produce the IgA in the mucosal lining, so that provides less protection against infection in infancy and then during later childhood as well. So when you think about where do they get most of their, what little bit of immune system they do have, where are they getting it from? Are they just have to develop it on their own? Do they have some that they get? If they do, where do they get it from? They do actually get a little bit of immunity from mom, right? So things that mom was exposed to, certainly during pregnancy, how good her nutrition is, that certainly plays a role in her immune system function, as well as if it is a breastfed infant, they can get some of those good um, antibodies to different things to help boost their immune system. So if they're an exclusively breastfed, or even if they're not exclusively breastfed, any breast milk they get is a bonus because that certainly is giving them good antibodies to help protect them. And then part of how we else build their immune system, guess what? Immunizations. It's artificial immunity, right? So they don't have to be exposed and go through some of those diseases that we've practically eliminated. Fortunately, we've seen some come back recently, especially like measles. We've heard a lot about that one, right? So immunizations are an important part of the immune system. Cardiovascular, again, over the course of the year, we're not talking about right when they first come out, because when they first come out, that heart rate is really fast. Especially if they start crying and get upset. It can be up almost 200, right? Depending on how upset they are. So that heart rate can be difficult to certainly learn to count. It takes a lot of practice. But the cardiovascular system, that heart rate slows and the rhythm is often what's called a sinus arrhythmia, which means the rate increases with inspiration and it decreases with expiration. So again, over the course of the year, the heart rate slows and the rhythm is often a sinus arrhythmia. You can read about the systolic and diastolic. That changes over the course of that first year and on throughout um, childhood as well. There are hemopoietic changes. Their fetal hemoglobin that is present for the first 5 months. So that's that hemoglobin that they develop while in utero. That fetal hemoglobin is present for the first 5 months. And then their adult hemoglobin that they start producing will steadily increase throughout the first half of infancy. That fetal hemoglobin is kind of important because as we start to see that fetal hemoglobin start to drop off, that adult hemoglobin that they're producing is starting to increase. And then when we get to nutrition, there's an important thing we're going to incorporate that's going to help offset um, what we talk about with the fetal hemoglobin because it has that shortened survival of red blood cells, which means they basically have decreased number of red blood cells that are circulating. Infants can easily get into what's called physiologic anemia. So when it comes to nutrition, we're going to incorporate something in their diet that's going to help try and prevent them getting into physiologic anemia. But physiologic anemia is not abnormal as long as it's not getting too low. It's certainly not too much of a concern. Their digestive processes. Man, don't we wish they could come out potty trained, save us some money, save us some stress that we're not having to potty train them, right? But they don't. That takes quite a while before we get to potty training. But their digestive processes, in general, they are immature at birth, for your blank, immature at birth. The majority of those processes don't actually even begin to function until about 3 months of age, and that's typically when you start to see drooling become more common. However, what most people put together with drooling is teething. And that certainly can be the case, but at 3 months, you typically don't have an infant who's cutting teeth quite yet. That takes a little bit longer, a few more months. So typically, when the drooling starts to increase, that's a sign that the GI system is maturing a little bit, not fully mature, but processes are certainly starting to begin functioning. And immaturity of their digestive system is certainly evident in their stool. If you gave them solid food, it's going to pass completely um, unbroken down. So it's going to be incompletely broken down. They have excess fiber that easily disposes or predisposes the child to loose and bulky stools. An infant shouldn't have large, bulky stools and loose stools. That's not normal. There is a difference in knowing a formula fed infant versus an exclusively breastfed infant or if they're getting a mixture. An exclusively breastfed infant typically has kind of yellow, mustard, seedy type poop. It's not formed. That's not going to start forming until we start incorporating, guess what? Solid foods in their diet. And even then, it's not formed, it's just more mushy and soft. Where, um, again, because of that immaturity of their digestive system, you wouldn't want to introduce solid foods too early because their body can't break that down. So thermoregulation. Thermoregulation just has to do with how well can they control their body temperature. And that becomes more efficient by 6 months of age. They start to develop what's called a shiver response to cold, and that increases because their adipose tissue or their fat tissue increases. So as that becomes better, they're able to have that shiver response and thermoregulate. Their renal function. They have immaturity of the renal system, which predisposes the infant to, when you think about fluid status in the body, what do you think? Predisposes them to dehydration. They cannot concentrate their urine at this young age. So they tend to also go a lot, very frequently. We're having to change diapers a lot. It's not real concentrated yet. So again, part of that is that immaturity of the renal system. Their complete maturation of the kidney doesn't occur until the later half of the second year. And then the last thing we're going to talk about with maturation of systems is sensory. Their auditory acuity is at the adult level, even in infancy, unless, of course, something else has come up, there's something going on that would affect their hearing. But typically, their auditory acuity is at the adult level, and their visual acuity improves over the course of the year, and they have what's called binocular fixation is established. And then depth perception begins to develop around 7 to 9 months of age. 7 to 9 months of age. So that's really important when you think about safety. That's why we always teach parents don't put them up on elevated surfaces and leave them unsupervised. Because guess what? When they become mobile and they start moving around, rolling, crawling, they don't know how high they are. So that becomes a real safety concern because they don't have that depth perception. And even when it begins to develop, it's just beginning. It is not matured enough to, again, be able to tell how high they are off of the ground or whatever surface they may be on. So depth perception begins to develop around 7 to 9 months. Okay, we're going to talk about developmental milestones. There's 4 areas that we look at, and that's gross motor, fine motor, language, and social emotional development. Starting with gross motor development, which the slide I'm on, you have that same slide or those same pictures in your notes. But when we think about gross motor development, what does gross motor development really mean? And think about it, I kind of referred to it earlier, and if you look at these pictures, it kind of gets into one of the first things we see in gross motor development, and that's head control, right? So think about that cephalocaudal direction of development from head to tail. One of the first things we have is head control. So we usually can see head control by age 3 months. So this series of pictures is just showing you progression. Usually at about 1 month or as a newborn, they have complete head legs. So if you lifted them, if they were laying on their back, and you lifted them just a little bit off the bed, that head's going to go straight back. They just do not have any muscle tone. That takes some time to develop. There's some things we can certainly teach parents to do. And one of the big ones that they teach to help develop head control is doing what's called tummy time. Just simply laying them on their belly for a few minutes every day because they'll learn to kind of move that head, turn it, and it'll help strengthen those neck muscles so that they can develop good head control. So usually about 1 month they have complete head lag. The second picture, the middle one, picture B, they have partial head lag. So getting a little bit more control. It's not just flopping back by 2 months, and usually by 3 months we should not have any head lag. We should have total head control. When you go over to the next slide, we'll talk more about progression of gross motor development. Gross motor development, continuing on, like in this picture, it's just showing you some tummy time, how, again, just a different angle of how we can see head control. And then we're going to talk about what comes next after head control. What do you typically see with gross motor? And really, what I didn't say in the previous slide, gross motor is really referring to those large muscle groups, right? So gross motor control really gets into movement, if you think about it. So our next thing we're going to see is rolling over. At what age do you think they start rolling over? It's usually a range, and most will turn from front to back, and then they will master back to front, and then once they've mastered both, they just roll all over the place. So they start rolling over usually around 4 to 5 months of age. They can typically hold their head steady when they're sitting momentarily without any sort of support. So if you just tried to sit them down on the floor with nothing around them, no cushions, we're not propped up in a corner of a chair or a couch, they can sit momentarily without any sort of support at age 6 months. Age 6 months. They can sit securely without support by 8 months. So going back one step, the 6-month-old, if you sit them there, they're only going to sit there for a few seconds, and guess what's going to happen with no support? They're going to face plant, fall backwards, sideways, something, right? Because they don't have that full control of their trunk of their body. So it'll only last for a few seconds, and then they will tip over. And then by 8 months, they can sit very securely without any sort of support, and they're not going to fall over anymore. So they sit securely without support at 8 months of age. They can get themselves into a sitting position alone, and they can pull up to a standing position by age 10 months of age, typically holding on to something, furniture, parent, most likely it's the furniture. They're pulling up to a couch or chair or something, coffee table if that's in the room, by age 10 months. This slide, same thing what you have in your notes, Just trying to show you again the development of that cephalocaudal direction of development, so meaning head to tail, right? When we first start out as a newborn, they don't have head control. If you try to sit them up, they're just going to have that very rounded back. Um, and then what happens is over a little bit of time, as some of that development starts to occur, we're not quite all the way hunched over. We're getting a little bit more up, getting some head control, and then we can sit um, with support, with full head control by 4 months. Again, we needing support. Remember, by 6 months, we'll sit just momentarily before we're going to topple over, fall back, fall sideways, face plant, whatever the case may be. And then usually by 8 months, they can sit very securely on their own, like in picture E. Please ignore the ages down in the bottom. Actually, it's just a guideline. It came from another resource. So you'll see slight differences. The numbers I give you are the numbers I want you to know for testing purposes, and they come from our textbook. In this slide, you can really see that progression of that cephalocaudal development, again, how they're able to get um, into a standing position, again, holding on to something. Even in picture E, you can see they're pushing up with their arms and getting into maybe starting to crawl and getting into that crawling position. And then, like picture F, we're starting to do more creeping and crawling on our hands and knees versus our belly is still touching the floor. So, fill in your blanks on that gross motor development that's continued. We have what's called locomotion, and locomotion again follows that cephalocaudal direction of development. So, head to tail direction of development. They start creeping or crawling with their abdomen up off the floor. So, usually up on all fours by age 9 months. When they start crawling, they can start crawling usually around 6 months of age, but they typically is more like an army crawl, or they're kind of scooting themselves along the floor. So the one I want you to know, they creep or crawl with the abdomen off the floor at 9 months of age. That's when they're up on all fours. They start walking with assistance or some sort of support. We call that cruising by 11 months. That could be certainly holding on to a parent, walking around furniture, or walking with like a little push toy. So we call that cruising. They do that at 11 months. And they typically take their first few steps alone. By how old do you think? If you're thinking by 12 months or 1 year, you're correct. So they typically walk alone their first few steps for 12 months. Again, they only take a few steps and then they're going to fall, but they start getting up, and that, again, over the toddler period is going to progress and get better and better. And next, we're going to talk about fine motor development. What do you think fine motor development really refers to? Well, fine motor development has to do with their hands. So go back to our other direction of development, and that was the proximal distal. So remember I said as a newborn they're going to come out with those clenched little fists and hands, and then over time those open up. That has to do with our proximal distal development. So fine motor has to do with being able to pick up things, grab onto things and hold them, or be able to transfer objects. So they can start grasping objects at ages 2 to 3 months. And typically when they start grabbing objects, they actually use the majority of the palm of their hand to pick things up, and all of their fingers. So they really start with that, like palmar grasp very early on, and then they're going to move out to just their fingers, and then over time they'll move into, like in the next slide, is the neat pincer grasp. Talk about that in just a moment. But they can start grabbing objects by 2 to 3 months of age. They'll start raking finger foods like Cheerios, those little cereal puffs, things like that, at age 6 months. And they can start to transfer objects between hands at 7 months of age. And then what this little guy is showing you is what's called the crude pincer grasp. And then there's also the neat pincer grasp, which is on the next slide. But the crude pincer grasp is typically where we're not using the palm of our hand anymore to pick things up. We're just using our fingers against our thumb. So that's called a crude pincer grasp. Not worrying about you knowing crude versus neat pincer grasp and what month that occurs at. For your notes, I just have pincer grasp develops by 10 months of age. So this little guy is demonstrating what's called a neat pincer grasp. And the neat pincer grasp, the difference is he's really just using his index finger and his thumb to grab on and pick up an object. So We can see that with the Cheerios. He's not holding one, but he's got some in front of him. Seeing kids pick those up with just those two fingers, the index and the thumb, that refers to a neat pincer grasp. And then the last blank, they are also able, right under your picture in the notes of the neat pincer grasp, they're able to remove objects from a container at 11 months of age. Let's take a minute and talk about some red flags in infant development or things that would be a nursing alert. And a lot of these really go with your gross motor and your fine motor development. So, some red flags. Any infant who displays a head lag after 6 months or at 6 months of age should have a developmental and a neurological evaluation. Because we said they should have head control by what age? By 3 months of age. So if they've got head lag at 6 months of age, they need to have a more in-depth developmental and neurological assessment to find out what's going on, what may be contributing to that head lag. An infant who does not pull to a standing position by 11 or 12 months of age, they need to be further evaluated for the possibility of something called developmental dysplasia of the hip, something we'll talk about when we get to musculoskeletal. There could be other reasons that certainly why maybe they're not pulling to a standing, but we would want to certainly look into if there's something going on that's preventing them from pulling to that standing position. So any infant who does not pull to a standing position by 11 or 12 months of age, that's a red flag. If they're unable to sit alone by age 9 months, because remember we said they should be able to sit alone without any sort of support by 8 months. So if they're not able to sit alone, unsupported by 9 months, that's a red flag. If they're unable to transfer objects from hand to hand by age 1 year, because they should be able to transfer objects by 7 months of age between hands. If they have an abnormal pincer grasp or grasp by age 15 months, that's a red flag. And the last red flag we're going to talk about is if they're unable to walk alone by 18 months of age. That's a red flag because they start taking those first steps when? By 1 year of age or 12 months, usually around their first birthday. So if at 18 months they're still not taking steps on their own, we need to do further developmental assessment and certainly look in more depth if there's something physically preventing them from doing that. Let's talk about language development. Language development for an infant. Starting out, at least, that definitely changes throughout the course of the year. But starting out, the infant's main means of communication is what do you think? They don't come out talking in full sentences and have words, right? So their main means of communication for your blank is crying. Is crying. They let you know if they're happy, they're sad, they need change, they need cuddled by crying. And parents can usually differentiate the types of cry. If it's a hungry cry, it's a just I'm not happy cry, I need change type of cry. Parents can usually differentiate that by 2 months of age. Um, Infants will start vocalizing as early as even 5 to 6 weeks, usually with kind of a throaty sound. By 2 months, they start cooing. Again, parents can differentiate the type of cry. I'm not going to go through all these. By 3 months, laughs out loud. 9 months, they start usually can say dada, and guess what? Dada is usually one of the first words they can say, or certainly they'll say dada before mama. Anybody know why? That's because dada is a whole lot easier to pronounce than mama. So they'll typically say dada first. By 10 months of age, they can usually say bye-bye or no. When they do learn the word no, that seems to be all they use, even if it's for something they want, right? So those who are in that stage or have been there maybe remember it quite well. They say no, no, no to everything, right? Even when they really want something. And then they get mad when you don't give them what they want because they said no, and you thought that's what they wanted, right? By 12 months, they can usually say 2 words in addition to mama and dada with meaning. So that might be bye-bye, no, go, something along those lines. Pretty simple words. Let's talk about language development. Language development for an infant. Starting out, at least, that definitely changes throughout the course of the year. But starting out, the infant's main means of communication is what do you think? Don't come out talking in full sentences and have words, right? So their main means of communication for your blank is crying. Is crying. They let you know if they're happy, they're sad, they need change, they need cuddled by crying. And parents can usually differentiate the types of cry. If it's a hungry cry, it's a just, I'm not happy cry, I need change type of cry. Parents can usually differentiate that by 2 months of age. Um, Infants will start vocalizing as early as even 5 to 6 weeks, usually with kind of throaty sound. By 2 months, they start cooing. Again, parents can differentiate the type of cry. I'm not going to go through all these. By 3 months, laughs out loud. 9 months, they start usually can say dada, and guess what? Dada is usually one of the first words they can say, or certainly they'll say dada before mama. Anybody know why? That's because dada is a whole lot easier to pronounce than mama. So they'll typically say dada first. By 10 months of age, they can usually say bye bye or no. When they do learn the word no, that seems to be all they use, even if it's for something they want. Right? So those who are in that stage or have been there maybe remember it quite well. They say no, no, no to everything, right? Even when they really want something. And then they get mad when you don't give them what they want because they said no and you thought that's what they wanted, right? By 12 months, they can usually say 2 words in addition to mama and dada with meaning. So that might be bye bye, no, go, something along those lines. Pretty simple words. Play is something else that we look at. We don't necessarily consider it a developmental milestone, but it is things that we do look at. The last developmental milestone we're going to talk about is emotional development, so that one will be next. But play, infant play is what we call or consider solitary play, meaning they're non interactive. The play is done by the work of the infant or work of the child. They're not going to sit down with another infant and interact. Their development cognitively, emotionally is not there. They do not understand that. I love when parents are like, "Oh, let's have a play date with the babies." That's well and good. I'm all for socializing and play dating. Maybe not right now, but infants don't understand, right? They don't have the ability to understand to share objects or toys. They don't communicate with one another. They're all about just playing with their own stuff and their own toys and them. Their play is very simple at this stage. And when they start to get older, a little bit different, you got to interact with them a little bit more. So, infant play is what's called solitary play. And this really reflects the infant's development and the awareness of their environment. They're very egocentric. Everything is theirs. This is why they do not understand sharing with another infant, right? They just steal toys back and forth and they get upset when somebody takes it because they see everything as theirs. They don't know how to share. That's not something we don't learn. Sharing's we learn when we're in preschool, right? So they're very egocentric. The infant likes to also develop their sensory and motor skills through manipulating toys and other objects. So a variety of types of toys, things that, if you think about like some of those crinkly like baby books or rattles that have different textures, um, objects that they can hit, especially as they get older, they can hit buttons and it'll light up or make sound. Those are all different ways that we can develop sensory skills, motor skills, because they can develop manipulate the toys to do different things, right? So you do have to be careful in this age group with the infant, and depending on the age of the infant, you should have a general idea of what are some good toys to give them, but you definitely got to be thinking about choking hazards in this group as a safety concern. You definitely don't want to be giving them toys that have small parts and pieces that could come off, because guess what? Guess where the infant's going to put it? Everything goes in their mouth, right? So we don't want a choking hazard. We want chunky, big toys, parts if they would come apart, no way that they could swallow them that it could become a choking hazard. We'll get into that when we get into safety. But I do have the different toys listed out per month. Please do not drive yourself nuts and memorize that. 1 month they like to just look at the caregiver's face. They do. They don't need anything fancy, which by 8 months, they like toys that have different textures and feels, or feel, not feels, sorry, have different textures to feel. And then by 12 months, they like to put things in and out of containers. So, like those shape sorters. I think about like those rings that are the different sizes that you stack on top of one another, like a little cone. Those are all good examples. And to think about like the toys that you're giving. Again, I don't want you to memorize all this. You'll drive yourself crazy. There's plenty of numbers to memorize as it is. But you should have a general idea of what kind of things, progression that they need. Think about cephalocaudal direction of development. Think about proximal distal. You're not going to give a 1 month old a container that has different sorting objects. They can't do it. They can't pick it up. They can't grab it. Not an appropriate type of toy, right? So think about that progression of development, that it being cephalocaudal or proximal distal. That'll kind of help you gauge what's inappropriate. Again, look it over. I'm not saying skip it, but look it over. But don't drive yourself at 5 months, at 3 months, at 6 months. Don't do it. Just have a general idea of appropriate toys so you can apply it. Play is something else that we look at. We don't necessarily consider it a developmental milestone, but it is things that we do look at. The last developmental milestone we're going to talk about is emotional development, so that one will be next. But play, infant play is what we call or consider solitary play, meaning they're non-interactive. The play is done by the work of the infant or work of the child. They're not going to sit down with another infant and interact. Their development cognitively, emotionally is not there. They do not understand that. I love when parents are like, "Oh, let's have a play date with the babies." That's well and good. I'm all for socializing and play dating. Maybe not right now, but infants don't understand, right? They don't have the ability to understand to share objects or toys. They don't communicate with one another. They're all about just playing with their own stuff and their own toys and them. Their play is very simple at this stage. And when they start to get older, a little bit different. You got to interact with them a little bit more. So infant play is what's called solitary play. And this really reflects the infant's development and the awareness of their environment. They're very egocentric. Everything is theirs. This is why they do not understand sharing with another infant, right? They just steal toys back and forth and they get upset when somebody takes it because they see everything as theirs. They don't know how to share. That's not something we don't learn. Sharing's we learn when we're in preschool, right? So they're very egocentric. The infant likes to also develop their sensory and motor skills through manipulating toys and other objects. So a variety of types of toys, things that, if you think about like some of those crinkly like baby books or rattles that have different textures, objects that they can hit, especially as they get older, they can hit buttons and it'll light up or make sound. Those are all different ways that we can develop sensory skills, motor skills, because they can develop manipulate the toys to do different things, right? So you do have to be careful in this age group with the infant, and depending on the age of the infant, you should have a general idea of what are some good toys to give them, but you definitely got to be thinking about choking hazards in this group as a safety concern. You definitely don't want to be giving them toys that have small parts and pieces that could come off, because guess what? Guess where the infant's going to put it? Everything goes in their mouth, right? So we don't want a choking hazard. We want chunky, big toys, parts if they would come apart, no way that they could swallow them that it could become a choking hazard. We'll get into that when we get into safety. But I do have the different toys listed out per month. Please do not drive yourself nuts and memorize that. 1 month they like to just look at the caregiver's face. They do. They don't need anything fancy, which by 8 months, they like toys that have different textures and feels, not feels, sorry, have different textures to feel. And then by 12 months, they like to put things in and out of containers. So like those shape sorters. I think about like those rings that are the different sizes that you stack on top of one another, like a little cone. Those are all good examples. And to think about like the toys that you're giving. Again, I don't want you to memorize all this. You'll drive yourself crazy. There's plenty of numbers to memorize as it is. But you should have a general idea of what kind of things, progression that they need. Think about cephalocaudal direction of development. Think about proximal distal. You're not going to give a 1 month old a container that has different sorting objects. They can't do it. They can't pick it up. They can't grab it. Not an appropriate type of toy, right? So think about that progression of development, that it being cephalocaudal or proximal distal. That'll kind of help you gauge what's inappropriate. Again, look it over. I'm not saying skip it, but look it over. But don't drive yourself at 5 months, at 3 months, at 6 months. Don't do it. Just have a general idea of appropriate toys so you can apply it. Emotional development. That's the last one we're going to talk about when it comes to developmental milestones. Emotional, or sometimes you'll hear it as social development, emotional social development. Emotional social development. That varies obviously over the course of the year. By 3 months of age, they are able and they're demonstrating increase social awareness, and they do that by readily smiling when they see mom or dad's face, or somebody familiar that they like, usually parents. They'll smile because that they're like, "Ooh, I like that face. I know that person." So they'll readily smile. They're laughing out loud. We saw that with the language development. They're laughing out loud. By 5 months, they are starting to show displeasure when an object's taken away. Um, so we call that object preeminence. So if you had like a ball or a favorite toy that or rattle, I don't know, something that they really like, maybe a stuffed animal, if you took that and you hid it behind your back, they can't see it, right? Out of sight. To them, it's out of sight, out of mind. They think it's gone forever. Right? So that's called object preeminence. They don't understand that it's just hidden behind something or behind whether it's your back or a couch cushion or a pillow or something. Um, and then you bring it back out and they're happy again, right? And you put it back. They're going to show displeasure when something's taken away. Right? Stranger fear starts to occur around 7 to 8 months. That's when they really start to develop a lot of anxiety and fear over strangers. They really might cling to mom and dad. They shy away, like turning away if somebody is trying to like talk to them, or different examples. There's a couple of examples in this picture. Right? They just don't like anybody that they don't know. And that could even be somebody within the family, like grandma and grandpa. Maybe they don't see them as often. And they really cling to mom and dad. Right? Bury their face in their shoulder or their shirt. By 12 months, they're starting to overcome the fear of strangers. They're not completely over it. Sometimes that takes a while. Every kid's different too, right? You have introverts, extroverts, but they're starting to overcome a fear of strangers, and they're a little more alert and responsive when approached, meaning they don't just outright start crying. You still get some who do, but a lot of them are starting to get over that, and they might be a little weary, but they're not bursting into tears and crying over the fear of a stranger. Emotional development, that's the last one we're going to talk about when it comes to developmental milestones. Emotional, or sometimes you'll hear it as social development, emotional social development. Emotional social development, um, that varies obviously over the course of the year. By 3 months of age, they are able and they're demonstrating increased social awareness, and they do that by readily smiling when they see mom or dad's face, or somebody familiar that they like, usually parents. They'll smile because that they're like, "Ooh, I like that face. I know that person." So they'll readily smile. They're laughing out loud. We saw that with the language development. They're laughing out loud. By 5 months, they are starting to show displeasure when an object's taken away. Um, so we call that object preeminence. So if you had like a ball or a favorite toy that or rattle, I don't know, something that they really like, maybe a stuffed animal, if you took that and you hid it behind your back, they can't see it, right? Out of sight. To them, it's out of sight, out of mind. They think it's gone forever. Right? So that's called object preeminence. They don't understand that it's just hidden behind something or behind whether it's your back or a couch cushion or a pillow or something. Um, and then you bring it back out and they're happy again, right? And you put it back. They're going to show displeasure when something's taken away. Right? Stranger fear starts to occur around 7 to 8 months. That's when they really start to develop a lot of anxiety and fear over strangers. They really might cling to mom and dad. They shy away, like turning away if somebody is trying to like talk to them, or different examples. There's a couple of examples in this picture. Right? They just don't like anybody that they don't know. And that could even be somebody within the family, like grandma and grandpa. Maybe they don't see them as often. And they really cling to mom and dad. Right? Bury their face in their shoulder or their shirt. By 12 months, they're starting to overcome the fear of strangers. They're not completely over it. Sometimes that takes a while. Every kid's different too, right? You have introverts, extroverts, but they're starting to overcome a fear of strangers, and they're a little more alert and responsive when approached, meaning they don't just outright start crying. You still get some who do, but a lot of them are starting to get over that, and they might be a little weary, but they're not bursting into tears and crying over the fear of a stranger. All right, now we're going to move into promoting infant safety. And the very first topic we're going to talk about is injury prevention. This is a huge topic. This is one of those big topics, especially in NCLEX, talking about safety and teaching when it comes to safety. So there's a lot in this category. I have several slides. A lot of them are just visuals just to show you different examples of some safety things that we do with infants. But lots of education that we need to make sure families know about. So parents need to know, one of the first things, parents need to know the number to local poison control center, and that's just 1-800 222-1222. This day and age, think about we've all got cell phones. The majority, not many people have home phones. The big thing is either tell them program it in their cell phone because in an emergency, they don't want to panic like, oh my God, I can't find it. Um, or if they do have a home phone, putting it right by the home phone or putting it on the refrigerator that it'd be easy to locate if they would ever need it in a time of emergency. And it's always important to make sure, as long as the infant or the child is not in any sort of uh, respiratory distress, I'll get my words out, um, or as long as they're still breathing, then they really need to call poison control first, and don't do any sort of inducing vomiting, unless poison control tells them to do so. So if they've swallowed something, they've taken something, medication they found maybe on the floor, they got into a cleaning product and swallowed it. Always important, as long as they are still breathing and they're stable, to make sure parents should call local poison control. Call that number, tell them what it is you think they had, how much. They'll ask a bunch of questions. The old, induced vomiting by giving ipecac syrup or stick a finger in their throat. You don't do that unless poison control tells them to do that. Because depending on what they potentially ingested, especially thinking about cleaning products, a lot of those are corrosive. And if you induce vomiting, we could actually create more problems and cause more damage to airway or their esophagus by inducing vomiting. So, unless poison control tells them to do that, we do not do that anymore. Again, poison control should be the first call, unless, of course, the child is in severe respiratory distress, turning blue, they're not breathing, something like that. Then, of course, call 911 first. When it comes to injury prevention, infants need constant vigilance, especially once they become mobile. Right? Constant vigilance, awareness, and supervision is needed. Right? When they become mobile, they're into everything. They're all about exploring. Um, Choking, huge risk. We've already kind of talked about that with play a little bit. So making sure we have appropriate toys, not things that have small parts and pieces that could come off, because infants are putting everything in their mouth. That's how they explore. The mouth is pleasurable to them. They don't know if it's good, bad, or nasty, putting it in their mouth. That's just how they explore their environment and the things around them. The caregiver themselves, they must actually physically remove the infant from dangerous situations. Just telling them no, don't do that. They don't have the cognitive development to understand that, why it's a danger. So a caregiver needs to physically remove them. When we think about car safety, which I've got one picture here, I've got another one in a couple of slides, but car safety, what do we teach parents about how infants should be, where they should be placed, which direction, and how long they should be in a car seat. So current recommendations for infants and toddlers is to ride rear facing. Current recommendation is to ride rear facing in car seats until they reach the age of 2, or height recommendations by the manufacturer. You're going to see a difference when we go to toddler. They'll actually say height and weight recommendations. Because usually in the infant period, the infant is not going to outweigh the restrictions or the limits of the car seat. So rear facing till age 2, or by height recommendations of the manufacturer. Great. You'll also see that I refer you to a box in your book, box 29.5. It's unintentional injury prevention measures for infant. All I've done in your notes have listed the categories in that box. I highly recommend, if I refer you to a box, a table, you need to go look it over. It's important. At some point in time, something's going to come up on an exam or a quiz or something. So go look that over. There's different ones. I'll mention a few of them. And then the next few slides, I'm not going to go through each one. They're just some visual representation of some of these safety measures we certainly want families to put into place. So thinking about like aspiration risk, again, that goes back to partly like the types of toys they play with, making sure they're appropriate. Also thinking about their food. When they start doing solid foods or they're starting to get into finger foods, making sure we cut them up into small bites and pieces, things that are easy for them to chew up. We don't want hot dogs or grapes that are left whole or even in half. They should be cut smaller because those airways are small. It wouldn't take much for them to choke on those. Thinking about liquids, don't put them to bed with a bottle, right? Aspiration risk, big time right there. Thinking about falls, what kind of things could we teach a family about prevention of falls? Safety gates. Safety gates should really be at the top and bottom of stairs, not letting infants play on the stairs. Um, Thinking about, again, not putting them up on elevated surfaces, even from the beginning when they're not mobile, but especially when they start to become mobile and they're rolling over or crawling. We don't want to put them on elevated surfaces because that depth perception is not there. Motor vehicles, again, that's talking about making sure they're in an approved car seat. They are rear facing. They're actually strapped in. Thinking about too with that, um, even though we're kind of getting out of the winter, still some pretty chilly days out there. But thinking about like when wintertime, we don't want a lot of layers on, and you do not have like a winter coat or an outer layer type coat placed on the infant, and then the infant in the car seat with the straps over the coat, because the problem is you can't get those straps tight enough. If there was an accident, they can easily come out of those straps, and they are no longer considered as safe when you have all that bulky clothing. It's always better to warm up the car, have blankets over the child, just dress them in a normal layer of clothing, not have that outer wear type of clothing or lots of layers of clothing on them in the car. Suffocation and drowning, never leave them unattended in a bathtub or around swimming pools as they become um, bigger and more mobile. Certainly need to think about animals in the household, cats, dogs, whatever, that there's concern there. Poisoning as well. Poisoning that could be from plants, that could be from medications, cleaning products, making sure we have all of those things put up. So when it comes to prevention of poisoning, we like to say, especially like medication and cleaning products, they need to be up high and in a locked cabinet. I cannot emphasize that enough. High and locked, high and locked, high and locked. You want to be doing that teaching parents to do that from the beginning, because when that kid becomes mobile, they're going to forget about it, and all it takes is a few seconds for them to be out of the room or turn their back, and the child has learned how to climb up on furniture or using drawers, cabinets, and they're getting into those things. So from the beginning, high and locked for all medications and cleaning products to prevent accidental poisoning. Burns as well, thinking about water temperature in the home. What do you think we should recommend parents to set their water heater no higher than? No higher than 120. 120 is the max. They can still get burned with a water temperature of 120 degrees, but no higher than 120. As infants become a little bit older, especially when we think about toddler, pushing handles of pots and pans back so they can't reach them, making sure that we don't have, if we're warming up formula or breast milk, that it's not too hot. You never use a microwave to warm that stuff up because you get uneven heating and hot spots, and then you can have burns that way as well. Again, make sure you go look at that box, look that over, kind of have a good idea of what some safety prevention measures are for infants. That's certainly a hot topic when it comes to safety. Just a couple examples. Again, the safety gates. Don't let them chew on electrical cords or play in electrical outlets. That's why outlet covers are really important. So just a couple other examples of some safety measures. In this slide about poison prevention, we've kind of already hit on it, but again, cannot emphasize it enough. High and locked, high and locked, high and locked. If you click on the little poison link, it'll take you to a fun little video about poison management, meaning trying prevention, and knowing the poison control center number for parents as well. So check that out. Again, I like fun things that'll make things stick. We're going to talk about promotion of nutritional health of the infant. Nutrition in the first year. Again, ultimately, the mother's choice if she wants to breastfeed or use formula, but we usually promote that breast milk is best. So, breast is best is kind of our saying. If for any reason the mom chooses not to breastfeed or breastfeeding is discontinued, and they choose to do formula feeding, they just need to make sure they're on an iron fortified formula. And in this country and most of our, not most, all of our standard formulas, if you go into the grocery store the next time you're there, and you go down the aisle and you see where all the formula is, if you look at it and you start really looking closely, they are all um, iron fortified formulas. They do need to be iron fortified, and that's partly because to make sure they're getting enough iron for development, we need that because those fetal iron stores are going to be dropping that I mentioned earlier about the fetal hemoglobin. Those last for about the first 5 months. So again, iron fortified formula if they're not going to be breastfeeding. We want to make sure they're having high protein, high calorie intake that is necessary for that rapid growth that they're going to have during the infant period. We can start solid foods at around 4 to 6 months of age. And we'll talk about some solid food additions like when they're ready for that in the next slide. But solid foods usually around 4 to 6 months of age. And then we typically start, when we do solid foods, we start with rice cereal first, and then we move on to wet. Are you going to do fruits, then veggies, or veggies, then fruit? You want to do veggies, then fruit. So if you're blank, veggies, then fruit. Reason you want to do veggies first, and that's because if you start with fruits, those fruits are naturally just sweeter, and they tend not to want to go back to the veggies, which aren't as sweet. Some of them are really bland. So you might have a little more of a challenge if you start with those fruits. So always teach parent to start with veggies first and then fruit. All right, first off, disclaimer, this is not a real infant solid food. It's just something funny. I'm all about, again, finding little bits of humor, break it up. But let's talk about solid food additions. How do we know when they are ready for solid food to be added to their diet, whether they're breastfed or formula fed? We certainly look for some readiness signs. Some of those might be what we call a decrease in the extrusion reflex. And the extrusion reflex is when they use their tongue and they push out either food or milk with their tongue. So you'll see them a lot of times just kind of pushing their tongue out. That's called the extrusion reflex. That tends to start to decrease, as well as we want to see the baby have doubled their birth weight. And when do they typically double their birth weight? By 6 months of age. And then they need to make sure that they have head control when they're sitting propped. So head control by 3 months. So they can sit propped, usually like in one of those reclining high chairs or booster type seats or a bumbo seat where they can sit again propped with head control. That's usually around, again, 4 months that they can, or at least sitting up like that in those type of seats. They should have head control by 3 months. And the reason we want to start solid foods around the 4 to 6 month weight, when they've hit those things, they've doubled their weight, they have head control, that extrusion reflex is decreasing. And guess what? When you go back to maturation of systems and thinking about the GI system, what are you going to start seeing more of? Drooling, right? That tells you those GI processes are starting to mature. The reason we want to incorporate solid foods is because go back to the hemopoietic changes. That fetal hemoglobin is present for the first 5 months. So when those fetal iron stores are starting to drop off, guess what we're starting to incorporate into the diet? And that is solid food. First one we have is rice cereal. Rice cereal is iron fortified. So we're going to give rice cereal, those iron stores end at 4 to 6 months. So as that starts to dip down, we're incorporating iron into their diet to help offset that, try and prevent that physiologic anemia. They should also be taking about 1 quart of milk per day. When I say milk, we're talking about breast milk or formula. I'm using that interchangeably. You only want to introduce one food every 4 to 7 days. And the reason you only want to introduce one new food at a time is you want to watch for allergies. You don't want to introduce 2 different new foods because if they would develop an allergy, you wouldn't know which food it is. So once you've mastered one food and there's no allergies, then you can move on to the next one. So whether you start with green beans, they've done great, no breakouts, so then you can maybe do sweet potatoes or something like that. Right? So human milk or formula is ideal for the first year. And then after the first year, once they turn 1, then we can switch them to whole milk. So we do whole milk after 1 year of age until 2 years of age. So human milk or breast milk or formula for first year, and then whole milk after 1 year of age. So 1 year to 2 years, they do whole milk, and once they hit 2, then we can go to 2% milk. We recommend egg yolks after 6 months of age, and that's because it contains the bulk of the iron is in the content of eggs. the egg yolk alone first because egg whites tend to lead more to allergies, and they're a little more difficult to digest. Meats are usually introduced at around 9 months, again, because your iron stores are starting to become more depleted when we're trying to prevent that physiologic anemia. So we want to make sure they're getting a good source of iron. Never use honey sweetener or honey as a sweetener, especially at this age. What we're worried about is botulism. Again, their immune system's not that strong, so we don't want to be using honey for any reason as a sweetener. Now, when they're older, after the age of 2, it's usually not an issue, but definitely once when they're a year old, honey is not recommended because of the botulism spores. And we want to make sure we're never using cow's milk instead of like an iron fortified formula or breast milk. So cow's milk, absolutely don't want to be using it. Again, it's because their digestive processes aren't mature enough to handle that. They can't quite break those proteins down, so it can lead to microscopic intestinal bleeding. We can start talking about weaning. Weaning can be accomplished when the infant's able to drink from a cup with handles. They can usually do that around or after 6 to 9 months of age. Again, go back to think about your proximal distal development. When can they start holding objects, not really holding objects, but transferring objects between hands? That's at 7 months. So 6 to 9 months, they can start switching from a bottle to a cup with handles, like especially at meal times, because when we start doing a little bit more of that solid food intake, start introducing that cup with a handle. Perfect time for them to do that. Right? Breastfeeding. Milk is produced on demand, so the mother needs to nurse the infant often, and oftentimes, especially with those growth spurts, mom's milk production will increase with those more frequent feedings and have time to adjust to the demands of the infant. It is important to teach the mother as well to make sure she's taking in plenty of fluids herself to replace that fluid loss that's lost in milk production. Also important to teach to make sure she nurse from both breast at each feeding, starting with about 5 minutes on each breast. As she gets more adjusted to her routine of breastfeeding, some women will do one breast and one feeding and then the next breast do the next. In the beginning, it is best to really try and have them nurse on each breast. Again, expect increased frequency with nursing during those growth spurts for your blank. So with growth spurts, the first few that we see, there's more beyond this, but the first few that we see, usually within about 1 week of birth, at 4 to 6 weeks, and then again at 3 months. Ideally, again, we always say breast is best. Continue breastfeeding for at least 6 months, if possibly a full year. Some women will even go longer than that. It really, again, part of that is sometimes a personal preference or choice. Um, when mom's ready, when baby's ready, they both have to mutually be ready to stop breastfeeding. And what some people will do is give up daytime breastfeeding, but maybe the nighttime feeding persist a little bit longer. Anytime breastfeeding is discontinued, again, during the infant period, we're talking about anytime breastfeeding is discontinued, they need to be on a commercial iron fortified formula. And talking about formulas, you can kind of review again the things you would want to teach to a parent about how to prepare, how to warm up formulas, how to store it, when to discard it. All of those are important pieces of information for a parent who is going to be bottle feeding or formula feeding an infant. Sleep and activity. Infants require quite a bit of sleep. They usually sleep about 10 to 12 hours of sleep per night. Now, that does not mean they're sleeping the entire 10 to 12 hours without waking. They usually wake up, take a feeding, go right back to sleep. So typically that is roughly about 10 to 12 hours of sleep per night. They're requiring one or more naps during the day, minimally one. They should really be taking 2 to 3, especially during the beginning of the infant period. Some infants nap longer than others, but at least one good nap a day, ideally 2. Some are taking 3 naps a day. Infants are naturally active. And when we're talking about sleep, we want to put them on their back to sleep. We call that the back to sleep campaign. So at least putting them on their back until they're able to roll over on their own. Again, they start rolling over at 4 to 5 months. Even once they're able to roll over, we usually always put them on their back first. If they roll over, that's okay. You don't have to keep putting them on their back because they're able to move their head and roll so that we don't worry about suffocation. Your next area of discussion is about promoting healthy family functioning and starting with teething. Infants start teething and they start with their baby or what we call their deciduous teeth. Those are actually formed in fetus, but they will begin to erupt around 6 months of age. So remember when I talked about maturation of systems and how that GI system we start to see drooling? That means when that increased drooling, that those GI processes are starting to function. Well, again, they don't start teething at 3 months. So, yes, drooling is typically thought of with teething, but they're not going to start erupting those baby or deciduous teeth until 6 months of age. Usually, the first ones that come in are those little central incisors, just like the picture on this slide. Those little two bottom teeth are what come up first. Then they'll have their upper central incisors and then their upper lateral incisors. Teething can cause pain, runny nose, irritability. It does not cause a high fever or an upper respiratory infection. That's what URI is, upper respiratory infection. It does not cause those things. Some signs of teething can include, for your blank, drooling, rubbing their gums or gum rubbing, increased finger sucking, biting on hard objects, maybe having difficulty with naps or sleeping, refusing to eat those solid foods. Those gums are irritated, they hurt, right? So, those are different ways that they manifest some of those signs of teething. It's a result of inflammation. Result of inflammation. So cold can be soothing. A topical anesthetic. Use of acetaminophen or ibuprofen. Again, age dependent. Can't start ibuprofen until 6 months of age. When I say cold is soothing, don't need anything fancy. I mean, you could simply just get a wash rag, get it wet, wring it out, put it in the fridge, and get it cold. Do not put it in the freezer. Same thing with teething rings. Don't put it in the freezer and take it out when they seem like they're teething and having some pain and give it to them because you can actually cause too much damage with the temperature. It's too cold. Just simply put it in the cold refrigerator, and that will be more than enough. Topical anesthetic, typical what we talk about is like Oragel. Of course, now you'll find, different reports that say Oragel is bad for infants. Well, you know what? I think there's people out there who probably just didn't follow directions, kind of ruined it for everybody else. So now they say don't do Oragel, that's bad. If you're going to use something like a topical anesthetic like Oragel, just need to make sure family is following the instructions, not using it too much, not using too much. You just need a little small amount to rub on those gums. The reason why there's research or articles out there that say no, you shouldn't do that. Well, again, somebody probably didn't follow instructions, and it's a numbing anesthetic. So then you're if you're using too much or putting it in like on the tongue or the cheek, I shouldn't say the tongue. Or I mean, I shouldn't say the cheek. I should say the tongue. If you're rubbing that and that's numbing that area, then we're at risk for aspiration and things like that. Again, use of Tylenol, ibuprofen, can't do that until at least 6 months of age. During the first 2 years of life, the number of teeth that they will cut, the way you can kind of figure out the average number that teeth they should have, take the child's age in months and subtract 6, and that should tell you minimum number of teeth they have. So an example, 8 months of age minus 6, they should have minimally have 2 teeth by 8 months old. That nursing alert, these are just some old kind of like wise tales that or old remedies for cutting teeth. We do not recommend any of these. We don't promote any of these. And if you think some of them are kind of silly, some of that belief is still out there. Rub whiskey on their gums, put a little in their bottle. Well, I'm sure it helps because it probably kind of knocks them out, makes them a little bit sleepy. But we do not recommend that. We don't want to rub anything on the gums like aspirin or cut the gums, trying to help the teeth come through a little bit quicker. We worry about infection and irritation and things like that. Don't want to give hard candy. That's a choking hazard or aspiration risk as well. Your next area of discussion is about promoting healthy family functioning and starting with teething. Infants start teething and they start with their baby or what we call their deciduous teeth. Those are actually formed in fetus, but they will begin to erupt around 6 months of age. So remember when I talked about maturation of systems and how that GI system we start to see drooling? That means when that increased drooling, that those GI processes are starting to function. Well, again, they don't start teething at 3 months. So, yes, drooling is typically thought of with teething, but they're not going to start erupting those baby or deciduous teeth until 6 months of age. Usually the first ones that come in are those little central incisors, just like the picture on this slide. Those little two bottom teeth are what come up first. Then they'll have their upper central incisors and then their upper lateral incisors. Teething can cause pain, runny nose, irritability. It does not cause a high fever or an upper respiratory infection. That's what URI is, upper respiratory infection. It does not cause those things. So signs of teething can include, for your blank, drooling, rubbing their gums or gum rubbing, increased finger sucking, biting on hard objects, maybe having difficulty with naps or sleeping, refusing to eat those solid foods. Those gums are irritated, they hurt, right? So those are different ways that they manifest some of those signs of teething. It's a result of inflammation. So cold can be soothing. A topical anesthetic, use of acetaminophen or ibuprofen, again, age dependent. Can't start ibuprofen until 6 months of age. When I say cold is soothing, don't need anything fancy. I mean, you could simply just get a wash rag, get it wet, wring it out, put it in the fridge and get it cold. Do not put it in the freezer. Same thing with teething rings. Don't put it in the freezer and take it out when they seem like they're teething and having some pain and give it to them, because you can actually cause too much damage with the temperature. It's too cold. Just simply put it in the cold refrigerator and that will be more than enough. Topical anesthetic, typical what we talk about is like Oragel. Of course, now you'll find, different reports that say Oragel is bad for infants. Well, you know what? I think there's people out there who probably just didn't follow directions, kind of ruined it for everybody else. So now they say don't do Oragel, that's bad. If you're going to use something like a topical anesthetic like Oragel, just need to make sure family is following the instructions, not using it too much, not using too much. You just need a little small amount to rub on those gums. The reason why there's research or articles out there that say no, you shouldn't do that. Well, again, somebody probably didn't follow instructions, and it's a numbing anesthetic. So then you're if you're using too much or putting it in like on the tongue or the cheek, I shouldn't say the tongue. I shouldn't say the cheek. I should say the tongue. If you're rubbing that and that's numbing that area, then we're at risk for aspiration and things like that. Again, use of Tylenol, ibuprofen, can't do that until at least 6 months of age. During the first 2 years of life, the number of teeth that they will cut, the way you can kind of figure out the average number that teeth they should have, take the child's age in months and subtract 6. And that should tell you minimum number of teeth they have. So an example, 8 months of age minus 6, they should have minimally have 2 teeth by 8 months old. That nursing alert, these are just some old kind of like wise tales that or old remedies for cutting teeth. We do not recommend any of these. We don't promote any of these. And if you think some of them are kind of silly, some of that belief is still out there. Rub whiskey on their gums, put a little in their bottle. Well, I'm sure it helps because it probably kind of knocks them out, makes them a little bit sleepy. But we do not recommend that. We don't want to rub anything on the gums like aspirin or cut the gums, trying to help the teeth come through a little bit quicker. We worry about infection and irritation and things like that. Don't want to give hard candy. That's a choking hazard or aspiration risk as well. Dental health. When we talk about dental health with the infant, it's nothing real fancy. The big thing is we just want parents to start cleaning those teeth when those teeth start to begin to erupt. Just teeth and gums are initially cleaned by just wiping with a damp cloth. Once they have more teeth, then we can move into the soft bristled brushes. We don't want to be using a regular toothbrush like you and I use. That'd be too harsh on their tender gums because they're already inflamed and irritated. So again, just starting out by wiping them with a damp cloth and then moving to a soft bristled brush as those more teeth erupt and the infant adjusts to that routine cleaning. Initial dental checkup, usually by age 2.5 years of age, and then just at regular 6-month intervals, just like you and I. Now, the Dental Association will say 1, and that's usually the 2 to 2.5, and then, or I might have it backwards, I can't remember now. When we go to toddler, you'll see I'll tell you by age 3. All I really want you to understand, because it's different associations talking American Academy of Pediatrics versus the Dental Association, all I really want you to understand, they need first dental checkup no later than 3 years of age. They should be getting fluoride supplements every 6 months. That can be done different ways. They do have fluoride nursery water. It's important to know is there fluoride in their home water, especially as they get older and we're getting off formula. Or again, when they go to the dentist, they can actually do fluoride treatments where they just brush it onto their teeth. Fluoride's important because that's going to help strengthen those teeth, protect them from dental caries. And of course, teaching parents how to prevent dental caries is important as well. We'll come back to that in just a little bit. Thumb sucking and use of a pacifier. Uh, Thumb sucking is important, or importance. There's importance with sucking in infancy. There's no reason to restrict it. Again, infants find oral stimulation in the mouth pleasurable. That's how they explore their environment. It's soothing to them. So no need to, as long what we call non-nutritive sucking, which is just again, it's they're not getting any nutrition from it. It's just a way oftentimes for infants to soothe themselves. No need to restrain that. Typically begins around 3 months of age, and that can be a habit that continues on through the first few years of life. Peak age of thumb sucking is 18 months. Tends to be most prevalent when they're hungry, they're tired, having feelings of insecurity. Again, it's just a way for them to soothe and cope with those types of things. A malocclusion can certainly become evident, especially if thumb sucking is persistent past the age of 4, because thumb sucking can disrupt the permanent teeth eruption that start to come in after age of 4. Pacifier use, well, that's really a parental choice and parental decision. There are benefits with a pacifier. It can be comforting to the infant, help with pain relief. It can help decrease SIDS, but there's also associated risks with it. It can lead to potentially increased incidence of otitis media. Some people think it has a negative impact on breastfeeding. It can certainly maybe have an impact, especially if you're using a pacifier well past age of when we use it, like past 2 or 3. It can cause potentially some malocclusion from that as well. So usually the relationship between pacifier use or thumb sucking, again, has to do with frequency and adequacy of feedings. Especially with pacifiers, there are some safety considerations to think about. On this slide, I have a picture of a multi-piece versus a single piece. With the multi-piece, we worry about pieces breaking, becoming a choking hazard, where that single piece, nothing's going to break off of that. There's no real choking hazard or potential choking hazard with that. And the other thing, if we were in class, I would have demonstrated an empty toilet paper roll and showing how that multi-piece pacifier can easily slide through an empty toilet paper roll, where the single piece, no matter which way I try and turn it, it's not going to go through there. And kind of like a rule of safety when it comes to toys and things like that, if it can fit through the empty roll of a toilet paper, it's too small for an infant to have, and it becomes a choking risk. So just kind of a general rule of thumb to go by. Certainly, too, other cleanliness with pacifiers. They fall on the floor a lot, not always the cleanest. But of course, you know, just like any other marketing place and businesses, they've come up with devices to be able to clip them to their shirts or to a blanket or something so they don't fall on the ground. But we also have to worry about strangulation. You don't want something that's too long that potentially could wrap around the infant's neck if it's on some sort of string. Colic. Colic, if anybody's ever experienced it, it is not pleasant to deal with. I dealt with it with my daughter. I don't think I'd wish it on anyone, not even on my worst enemy. I joke and say that it should be a form of torture because it is not fun to go through whatsoever. If you've been through it, you know what I'm talking about, and you're probably like kind of nodding your head to yourself. But colic is considered perioxysmal abdominal pain. They don't know why it occurs or for what reason, but they believe it's some abdominal pain or cramping that is manifested by loud crying. Typically, the infant might draw their legs up to the abdomen, their face might turn red, they'll clench their fists. You can tell the infant is in obvious pain and discomfort. The abdomen will become real tense, and the abdominal pain typically lasts up to 3 hours per day, and it occurs at least 3 days every week. So that's kind of how we determine that it's colic. There is no specific test we can do. So we look for patterns with their feeding. We ask about stooling. We ask about behaviors. How long are they crying? How often? What time of day is it? What relationship is it with the feeding? Really ask a lot of those characteristic kind of questions to kind of see what their pattern is. And really, we roll all these other things out and we go, well, it's probably colic. So, again, abdominal pain that lasts up to 3 hours per day, could be longer, and it occurs at least 3 days every week. I know with my daughter, when we went through it was pretty much consistent every day. Um, Most people will say there's a pattern a certain time of day. Me, I had more problems when it was during the daytime, fewer problems at night. Now, when I went back to work, my husband had more problems at night than during the day. So, it's just different. But I've had other students have told me, oh, yeah, we have a definite witching hour when this will occur. It becomes a pretty predictable pattern. It is more common under 3 months of age. So for your blank, more common under 3 months of age. The child or the infant will still continue to gain weight. They are thriving. They're growing like they should on those growth charts despite this pain. It is considered self-limiting, so really we just need to give it time for the infant to grow and mature. It usually will disappear around 3 to 4 months. I can tell you in my personal experience, that was the case, kind of looking back when she was 5 months old, looking back, going, yeah, we really started to turn that corner at 4 months. So again, everybody's different, but usually around the 3 to 4 month things will start to improve. Um, when a parent comes in and saying, oftentimes what they're going to say, if they don't know anything about colic, maybe it's their first child or first child that's ever had something like this, they don't know always to call it colic. They just come in going, my baby just cries all the time. I'm exhausted. I don't know what to do. It's really concerning to them. You'd want to ask some more detailed questions because that can help us rule out other things going on. So you'd want to get a detailed history. You'd want to ask about the infant's diet. Are they breastfed or are they formula fed? If they're breastfed, what's the diet of the breastfeeding mother? Because sometimes what mom is taking in her diet, that nutrition is crossing over to the breast milk. So sometimes there's something in mom's diet that's crossing over breast milk that's causing some irritation. So sometimes they'll ask mom, eliminate things out of their diet. One of the first things they'll ask the breastfeeding mother to do, cut out dairy. It's usually the most common offending food allergen, so oftentimes they'll say eliminate all dairy in your diet. Um, Again, it's usually kind of an elimination type diet, see if they get better. It's important to ask about the time of day when the crying occurs, the time of day when crying occurs. Is it morning? Is it afternoon? Is it evening? Is it middle of the night? When is that occurring? Because again, there's usually a pattern to it. What's the relationship with the crying to the feeding time? Did you just feed them? Has it been a couple hours? Haven't fed them yet? Whatever the case may be. And again, what's the characteristic of the cry? What's the duration, the intensity? We want to know those characteristics of the cry because that can help us. Again, parents can distinguish between, oh, this is a pain cry, this is a hungry cry, this is a I just need to be held or I need to be changed type of cry. So those things are important to ask. We also want to ask about what measures have they used to relieve the crying and how effective were they? So what have they tried? Have they switched formula? Have they eliminated something from their diet? Have they tried swaddling or carrying them or music? Something. What worked, what hasn't? Important to ask about the infant's stooling and voiding and sleeping patterns. Again, those are all clues to rule out other things going on. We'd want to know, what do their stools look like? How many wet diapers are they making? And again, is this affecting their sleep pattern, or are they sleeping okay? Um, Parents typically come in; they're frustrated by this. Again, if you've been through it, you know what I'm talking about. We really worry about not just mom, even both parents. I don't care who the caregivers are. They can become really frustrated by the infants crying. They feel like they're trying all these things, it's not working. And the biggest thing we're worried about is, do they get to that point where it's kind of like a breaking point, and we worry about potentially abuse because they're frustrated with the infant's crying. Nothing they seem to do seems to be working. That's how they feel, right? So take those concerns seriously. Make sure we're telling them there's nothing that they are doing wrong. So getting into your colic interventions, we want to reassure parents that they're not doing anything wrong. There's just nothing really we can do about it. The infant's not really experiencing any physical or emotional harm as long as parents aren't, detrimentally acting to that cry. We can teach parents to change the infant's position frequently. So in this picture on the slide, the mom is demonstrating what's called, or what is referred to as the colic carry, kind of putting the infant's abdomen on the forearm. Sometimes that gives some pressure to the abdomen to help relieve some of that discomfort and pain. So again, change the infant's position frequently. Swaddling them, swaddle the infant tightly. I know my daughter loved that. As long as she was swaddled tightly and being held, she was good. Oh my God, I could never get her in a bouncy seat into a swing. If I did, I was lucky if I got 20 minutes before she'd be crying. As long as she was swaddled up tightly and being held and carried around, she was good for the most part. I'm not saying she didn't cry, but it was certainly reduced. So, swaddling can be helpful. If they're a formula fed infant, maybe the type of formula is causing problems. I know that was one potential thing that we tried. She was getting mix of formula and breast milk at the time, and we found out she was having problems with the milk protein, wasn't able to break it down. I was seeing blood in her stool. Of course, we were also having all this crying, so we changed formula. Oftentimes, when they change formula, they'll recommend going to something like Nutramigen, Similac, or not Similac, I'm sorry, the Alimentum, which is from Similac, the Progestamil, Neocate, Elecare, something. A lot of times these are to help with like potential food allergies, or again, those milk proteins are broken down. There's all different ones out there. We don't want families just randomly changing formulas. And when they do change a formula, they've got to give it a good full 2 weeks for that to completely get out of the infant system. So it can take a while if they're changing formulas. We want to encourage small, frequent feedings. That's trying to help prevent any sort of distension or discomfort. Just trying smaller, more frequent meals instead of these larger bottles. Offer a pacifier. We did that a lot. That can be helped with soothing. Reducing stimuli. So, reducing a lot of the other noise in the room or background noise. Anything that can kind of stimulate them, we want to reduce that. Because again, the more stimulated they are, if they're not sleeping, parents aren't sleeping, everybody's frustrated and just kind of on edge. Car rides, playing music. Oh my gosh, car rides. My husband swore by them. He did a lot of laps around the Geist Reservoir when I was back to work, and he was having a lot of this colic issues with our daughter. So car rides can be helpful. That just that motion, that movement. Some people use, again, you got to think about safety. Bouncy seats that have the little vibrator in it, or simply just that motion. Again, swings can be helpful. If you don't have a bouncy seat that has the little vibrating seat in it, put them in the bouncy seat. Put that bouncy seat on top of the dryer and turn it on. One, strap the child in, buckle the child in, and don't leave the child unattended, right? Safety risk. But sometimes that vibration, that little bit of movement can help kind of calm them down. We do want to avoid use of heat or like heating pads. That's again because the possibility of burns. If you put a heating pad on the infant, they can't get away from it. They're not that mobile yet, so they can easily get a burn. So we don't recommend using that. Gas drops, like I have in the picture, we swore by those. We did gas drops a lot just to try and help reduce any gas or distension or any irritation. Gripe water, people talk about using gripe water. I never used it, but some people have a lot of benefit from using gripe water as well. Diaper dermatitis. Some infants have sensitive skin, that the diaper dermatitis can be a problem for first few days of life. It can occur for a variety of reasons, and sometimes it's not just the first few days of life. Sometimes there's infants who have problems just because they have really sensitive skin. They can have problems with the types of detergents you wash their clothes in, or the perfumes in the diapers, or the wipes. All different reasons. One of the most common is because parents just simply aren't changing the infant's diaper frequently enough. Anytime feces or urine is left in contact with the skin, that just breaks down the skin, irritates it, and then you kind of get sometimes in this vicious cycle. Prevention and treatment measures. One of the easiest things parents can do, just change them more frequently. So frequent diaper changes. Now, I'm not saying as soon as they pee this small little amount, you have to change them, but also not letting infants sit in these wet diapers that they're absolutely like soaking wet, heavy as can be when we change them. In today's commercial diapers, they are super absorbent. So they are designed to hold more. And I get diapers are expensive, but you also don't want that diaper to become so wet and so full from multiple episodes of urinating or feces that they're not getting changed because that just irritates that skin. So again, frequent diaper changes. Another thing we recommend, just some diaper like ointment, applying a skin barrier. Here's an example: A&D, Desitin, Bordeaux's butt paste, just like in the slide. They're all designed to kind of prevent or basically provide a barrier for the skin. So it's important to teach parents to apply that with every diaper change. And then just simply exposing the diaper area to air. Of course, you got to be careful. You expose a boy and girls too. Expose them too long, they're just going to pee again, either all over the place, all over you. However, you still want to make sure you dry that area and just simply let air get to it. You don't want to wipe them off with a diaper wipe and then put a new clean diaper on and it hasn't even dried because then you're just locking in this moisture, which guess what? You've already got irritated skin. It's just going to break it down further. So again, making sure they're kind of, I call it kind of airing them out. Just dry them off. Put a diaper underneath them. If you're worried about they might leak, put something over where they can pee if it's a boy or a girl. And then just simply, take a clean diaper and kind of wave some air, get them to dry, and then put that clean diaper on once their bottom of their skin is dry. The complication if parents don't do or aren't taking care of it, and this can still happen even when all the proper measures are being taken. Sometimes a complication of diaper dermatitis, it can turn into a fungal infection. And that's just simply when the diaper area becomes covered in lesions that are bright red. They can have oozing. Sometimes there's not oozing, it's just bright red. It lasts longer than 3 days. This is not your typical diaper dermatitis. They have red pinpoint lesions and it doesn't respond when it's a fungal infection. It doesn't respond to the typical diaper treatment measures or diaper dermatitis measures. The last topic we're going to talk about in the infant chapter is baby bottle tooth decay syndrome. Some people will also refer to it as bottle baby mouth. There's different verbiage, but idea is it's the same thing. It's when typically an infant gets put to bed with milk in their bottle. So, and that what happens is when that milk comes in contact with the teeth and it sits on the teeth, then it breaks down and results in decay of the teeth. So, baby bottle syndrome results from it could be milk, it could be fruit juice or any other kind of juice or formula that's coming in constant contact with those teeth while they're sleeping. Again, there's sugar in all of those things. It just breaks that down. It creates plaque, further breaking down and creating what we call dental caries. Prevention, we want to teach parents that absolutely no bedtime bottle. Now, I get it. Most infants usually like to nurse or have a bottle right before bed. That's fine. I'm not saying they can't have a bottle before bed, but you don't put them to bed with the bottle. So if you give them that bottle as part of that night routine, we clean their teeth, wipe them off, use a toothbrush, whatever we're using, and then no bottle after that, right? So no bedtime bottle. If we can't quite break that bottle, that routine, that habit, then substitute the breast milk or the formula or the milk or juice, whatever it is you're using, substitute with water at bedtime. So substitute water at bedtime instead of milk or juice. Again, trying to prevent those dental caries from occurring.